everybody. I'm Lucy Meehan, one of the radiologists here at VetCT, and I'm hosting for this evening. Welcome to the fourth and final webinar of our winter series. I'm just going to give it a couple of minutes to let a few more people in, and then we'll get started. Okay, so just a little bit of housekeeping whilst Rachel's running through the introductory slides. Everybody is muted on entry. We'd be really grateful if everybody could stay muted. That just makes life a little bit easier for us. If anyone has any questions, we will address those at the end of the talk. There is a chat button in the middle of the bottom part of the toolbar. If you want to type any questions in there, I'll be monitoring the chat throughout the presentation, and I will address any questions to Rachel at the end, and we'll work that way if that's okay with everybody. We will be recording the webinar, so there will be a link to the recording sent out following the webinar. It's usually sort of by Monday. If you haven't had it by Monday, do just give us a quick email because there may be some technical issues, but usually we get it out by the following Monday. So I will just introduce Rachel briefly. She needs very little introduction, and then we will start. So I'm delighted to introduce Dr. Rachel Murray this evening. Most of you will know Rachel, and she's a very, very experienced veterinary surgeon with a particular interest in advanced imaging, sports horse injuries and performance. I was lucky enough to work with Rachel at the Animal Health Trust, where she worked until 2019, and she now splits her time between working with VetCT, Rossdale's, and various other projects and roles within the sports horse industry. So Rachel's going to be talking to us today about MRI, and most specifically the utility of repeat MRI in prognosis and diagnosis in the equine patient. So without further ado, I will pass you all over to Rachel, and we'll start the evening. Thank you.
Thank you, Lucy. So I am talking about how follow-up MRI can be used to influence treatment or prognosis. And I am a big fan of using follow-up MRI. And I think the more I've used it, the more I've started to be keen on using it. So why should we do repeat MRIs? I think they can help us improve diagnosis because we understand more than one single point in time. When we can see more than that, we have an idea of where we are in an injury process or what's happening with it. We can assess the response to treatment, monitor healing, and also monitor response to training or exercise. And I think that helps us as veterinary surgeons in our decision making. And which is what we have to do on a day-to-day basis. So, not quite sure why my slides won't, there we go, they're now advanced. So if we're talking about different areas, I'll start by talking about the foot. And there's various things I was going to talk about in the foot. Obviously, I can't cover anything and everything, but I just wanted to pick out a few different things as we went along. So what about navicular bone fluid signal? This is something we see on a relatively frequent basis, and we associate with podotrochlear apparatus injury, often with other soft tissue injuries, but sometimes we see it on its own. So why might it be useful to look at this with repeat MRIs? And I think when we are looking at fluid signal in the navicular bone, what might happen to this? If we have an acute trauma, or a overloading, we may end up with a trauma, microfracture, bruising of the bone, which then ends up in recovery of the bone, which can happen really very rapidly. So we may see this recovery within a month or so, and then this gives us a much better idea of the prognosis for the horse. However, if we've got progressive pathology, which is going to end up in deterioration, This may look very similar as high signal intensity or high fluid signal in the navicular bone in the first place, but ends up with deterioration rather than recovery. So what might happen? We might end up with fluid signal associated with flexor cortex damage or progressing into flexor cortex damage. And this flexor cortex damage may be quite significant. We may see necrosis, we may see significant abnormality, and generally our prognosis would not be so good with this. And we may also, if we get development of flexor cortex erosions like we have here, we may end up with adhesions between the deep digital flexor tendon and the navicular bone, which has mechanical restrictions and may be associated with lameness. So, and if we have this damage and degeneration, this is a progression that we are likely to see on MRI. So if we MR our horse with high signal intensity on fat suppressed images, and then we re-MRI it at a later point, we are going to have an idea about whether this has got deterioration going on. If we MRI this horse 2 months later and we saw flexor cortex erosion, that would be not a good prognosis. However, if we saw MRI'd the horse 2 months later and saw resolution of the fluid signal, then this would be a much better prognosis. So this gives us a much better idea of how to, what sort of prognosis and management we need for that horse. For example, an endurance horse after a long race may have, on a hard surface, may end up having a high signal intensity on a navicular bone that will resolve very quickly. So a horse with a flexor cortex erosion, we would generally say would have a pretty poor prognosis or pretty guarded prognosis, but I wanted to put this horse in, which has been followed up, just to remind me and us that things that we assume are going to happen don't always happen. So this was a middle-aged warm blood leisure horse. It had a gradual onset lameness with an acute exacerbation, blocked to a parasagital nerve block. And we can see here we've got a significant flexor cortex erosion. In this area, we can see we've got high signal intensity on fat suppressed images in our navicular bone. On all different sequences and different orientations, we've definitely got a flexor cortex erosion there. So what happened with this horse? This horse was rested and on pasture rest, didn't do very much. And the horse had mild improvement, became not significantly lame, but then was represented 18 months later because it was more lame. And this is the navicular bone now. And you can see where we had the flexor cortex erosion before, we just have a little indentation and irregularity of the flexor cortex, but our significant flexor cortex erosion has filled in and resolved, and the high signal intensity on fat suppressed images in the navicular bone has resolved. So I think it's worthwhile remembering that even if we would anticipate or predict something in medicine, it doesn't happen. This horse does have significant osteoarthritis of the distal interphalangeal joint, which is where it blocked out at this stage. What about collateral ligament injury? So this is an example of follow-up in a 15-year-old Grand Prix dressage horse. This horse presented with moderate lameness, right fore, particularly on a right turn on a hard surface. And the horse was positive to a parasagital nerve block. So on this MRI at this stage, we have got evidence of fluid signal in the bone at the origin and of the insertion of the lateral collateral ligament. And you can see this around the collateral fossa. The collateral fossa is enlarged and distorted with obvious remodeling, as well as the fluid signal surrounding it. The collateral ligament itself has got increased signal intensity on 2,2 fast spin echo images extending through the ligament and into the insertion. And at the insertion, we've got what appears to be loss of ligament fibers and disruption of the bone ligament interface. And we can see this here on the transverse T1 images, which we've got significant distortion and damage at the insertion and damage through the ligament structure itself. So we've got middle and distal phalanx bone injury, pathology in the collateral fossa, and damage to the lateral collateral ligament. Now, this is quite a valuable horse, so we followed this horse quite closely and needed to decision make, because this horse had to attend a championship within a certain period of time, and we wanted to get the horse there. So, so this horse was monitored quite closely. Had a 3-month recheck, and if we look at the horse was in the meantime treated, managed with a shoe to support the lateral side of the foot, and was in a controlled exercise program in straight lines. At 3 months, the horse was sound and back in light work in straight lines. And we can see here we've got decreased stir signal intensity on both the middle and the distal phalanx. We've got decreased T2 phosphon echo signal intensity within part of the lateral collateral ligament. We've got a little bit of filling in of the fossa of the collateral fossa on the distal phalanx, but we still have got disruption of the ligament bone interface and some pathology still in the ligament. So at 3 months, we've got significant changes, but it's definitely not resolved. At a 5-month recheck, this horse is sound. It's still on straight lines only, but it's back in doing some collected work. And we can see further filling in of this fossa and of the ligament fibers. The ligament size is more normal and the signal intensity is more normal. We've got more fibrosis and filling of the ligament fibers, but we've still got a little bit of bone ligament interface disruption. So this horse was gradually put on increasing exercise at this stage. We felt from the MRI we were confident enough to keep going with the exercise, being very careful, putting in the turns at the very last minute. 8 months following the initial injury, the horse was sound and winning at International Grand Prix, and a 1.5 years later was still sound and winning International Grand Prix and placings at championships. So, so the MRI gave us the confidence to keep going with what we were doing and decision make through that process. What about distal phalanx bone injury? This is a 14-year-old Grand Prix dressage horse, which had a sudden onset, severe left forelimb lameness in the walk, which was worse on a right turn. The horse had no response to hoof testers, but the distal limb was warm, and a distal interphalangeal joint block was negative, but a Palmer digital was positive. When we look at the MRIs, we've got evidence of a deep digital flexor tendon injury, which we can see here on the frontal 2, but this has got primarily increase in signal intensity on a T1. We've also got damage, which I think it's not so clear on the screen, on the dorsal aspect of the other lobe, and we've got a mild increase in signal intensity here on a T2 phosphon echo. So we have got a deep digital flexor tendon injury, but what I felt fitted better with what was going on, or certainly might be part of what was going on, was this marked increase in fluid signal within the distal phalanx in the flexor aspect, but also extending dorsally from the area of insertion of the impar ligament. The navicular bone also has fluid signal, which is extending in line with this potentially strain of our navicular support ligaments. And you can see the navicular bone on various different sequences. We've got increased fluid signal and the marked increase in fluid signal in the distal phalanx. So for me, often a horse that has got severe lameness I will often see bone injury associated with these. And although they may be very painful with the soft tissue injury, I think that bone pain is often the most painful. So looking at this horse, was this going to be a degenerative? Was this going to progress? Was this an acute bone injury that was going to resolve? Was this going to relate to the deep digital flexor tendon injury? And this was a horse we wanted to follow pretty closely, pretty valuable horse. So it was re-MRI'd 1 month later. And we can see at this stage, it had been rested, non-steroidals. The horse was more comfortable than it was, but variably lame. We can see a more defined lesion here on the dorsal aspect of the deep digital flexor tendon with soft tissue accumulation adjacent to it, which was less clear before. A small focal area here, which again on the T1 is more obvious. We can see this horse has improved clinically. We have also got improvement here in the on I think my computer is not behaving. We can see that we've got improvement in the fluid signal in the distal phalanx and the navicular bone, where we've got significant improvement with decreased signal intensity on stir images. So we've still got generalized mild increase, but significantly better than before. So although the lesions in the navicular bone, in the deep digital flexor tendon are not significantly different, we've got soft tissue that's evident now, and we've got significant change in the bone. So at 3 months, this horse is re-MRI'd again prior to going back into full work. We've got a deep digital flexor tendon. These are evident, but primarily only on the T1 images now, with the soft tissue present here, and our bone fluid signal has resolved completely. So this is 3 months from where we are. This horse goes back into full work, at which point it was competing at top level. It was shod in an aluminium shoe to give it a little bit of cushioning effectively, and lightweight. 3 months later, this was getting high scores at International Grand Prix. So by following this horse, we were confident things were getting better and that the horse could then increase in what it was doing in work. So it really helped us with decision making, because in that first month we were pretty nervous about exactly what was going on. And following the MRI gave us more confidence what we were doing. So that horse followed again 2.5 years later. That horse stayed sound for 2.5 years competing at that level. And it had just gone mildly lame. And we can see at this stage, we don't have repetition of the bone injury, but we do have a development of the deep digital flexor tendon injury, which is advanced. But this horse has stayed lame, sound for 2.5 years. What about distal phalanx fracture? I think it's useful, it can be useful to follow these. It's useful to MRI these, not only in relation to the bone, but also in relation to the soft tissue structures. And a soft tissue structure that I'm particularly interested in looking at with the distal phalanx fractures is the insertion of the distal digital annular ligament, because the distal digital annular ligament inserts right in an area where we seem to get wing fractures. And I do wonder if this is related to biomechanics, and that's one of the reasons why we may get fractures. So I think this has knowing whether or not we have an injury to this and following the progress is particularly useful. So this horse had a sudden onset lameness on its right hind limb after it escaped from its field, jumping out of its field. It was very lame at walk. When I saw it, it was unshod. And you can see we've got a distal phalanx fracture here. And this involves the insertion of the distal digital annular ligament on the medial side, and it's often the medial side in my experience. So we followed this out. We MRI'd this at 3 months. The horse, this is a stallion who was particularly unimpressed with staying in a stable. He was shod in a bar shoe and was significantly more comfortable at this stage. He was sound in walk. So we re-MRI'd him with a for decision making about what we did at this stage. And we can see here that we have got we've got callus formation and healing here of the fracture, or the fracture is less defined. We've got much less fluid signal, and we've got a significant improvement in the distal digital annular ligament. So we allowed this horse to start doing more. It started walking and doing more at this stage, and this horse progressed well. So another horse with a similar type of injury, as an example, this is a promising show jumper 5-year-old gelding, which had a sudden onset severe right forelimb lameness. It was then sound, and when re-examined, it was lame again, in a straight line, when much more lame on a circle. It blocked to a DIP joint after 3 minutes. So on MRI, this horse has got a fairly classic wing fracture here, involving the insertion of the distal digital and annular ligament, which you can see has got really high signal intensity at this the bone ligament interface, and it's enlarged. So a recheck at 4 months, it had been sound for 2 months, being hand walked with a support shoe. And the question at this point at 4 months was, should we increase its exercise? So we did an MRI to help us plan. So we can see at this stage, we've definitely got infilling of the fracture line, and we've got improvement in the distal digital annular ligament, and we've got decrease in signal intensity on stir images in this area. But we've still got an obvious fracture line at this stage, even though it's healing. So we didn't think the horse should be going further than walking gently, but it gradually increased over time. And by 12 months, it was in full flat work. So the question at this point at 12 months was, could this horse go back to jumping? And the owners wanted to be confident at this stage that that would be a reasonable thing to do. So if we look, we've got significant filling in of the fracture line. We've got pretty much resolution of the fluid signal on stir images. We've got a small disruption in this area at the insertion of the distal digital annular ligament in the fracture line. So we then, at that point, we started the horse very carefully jumping, and then it progressed well from there. But it just about helping decision making at that point. The distal digital annular ligament injuries can occur without a fracture, and we can see here we've got a ligament bone interface injury here, and we've definitely got bone injury in that area too. So we've got a bone injury without a fracture line, and we've got disruption at the distal digital annular ligament insertion and the edge of the deep digital flexor tendon insertion. 3 months later, that has completely resolved in that area, and we've only got a small amount of fluid signal left. So the horse has been sound for 4 weeks and went gradually back into work at this point. The other one that I think is quite useful at this to look at in the foot with repeat MRIs is the dorsodistal bone injury of the middle phalanx. Here, the prognosis can be affected by associated damage. So articular cartilage and joint surface damage, associated soft tissue injury, and a lot of these will also have podotrochlear apparatus injury as well. So, for example, this one, it was an 8-year-old show jumper, which blocked out to the distal interphalangeal joint, was negative to a Palmar digital. And you can see we've got a significant dorsodistal bone injury of the middle phalanx. But in association with that, we have also got significant podotrochlear apparatus so we've got navicular bone injury. We also had navicular bursitis and distal interphalangeal joint synovitis. So we have got other things that are going on with the dorsodistal bone injury in the middle phalanx. middle phalanx bone injury in that area can have a reasonable prognosis and may recover very quickly if there is nothing else going on with it. I think this is an interesting one. This is a Grand Prix dressage horse which had a sudden onset mild lameness, which blocked to a Parasagital and improved with a DRP joint. We can see this horse has got a deep digital flexor tendon injury, and this is probably significant. It's evident as high signal intensity on T2 fast spin echo images. It might be that this is necrotic, and it might be that this is a recent injury. But either way, this is likely probably to have clinical significance. It also involves the dorsal margin here. So this horse was MRI'd again at 4 months to look for progress. And we can see as it got improved lameness, it was sound in a straight line and was ridden walking exercise. There was improvement in the deep digital flexor tendon. Again, there was improvement in the deep digital flexor tendon, but what I wanted to show here is, is that we don't have anything going on here, and we haven't in the first 2 MRIs. However, at 6 months, there was a recent recurrent of lameness. After it, the horse returned to work. So the horse was back in full dressage work. And at this point, we have got dorsodistal bone injury of the middle phalanx, which we can see here on all our different sequences. We've got mild changes in the navicular bone also, but the majority is here. So, so this horse originally had a podotrochlear apparatus problem, went back and then that improved, went back into work, and now we've got bone injury in the middle phalanx. At 8 months, we've got significant improvement. It's more isolated, it's less extensive, and the horse is in light work. It's got mild lameness. By 9 months, the horse is sound in walking exercise and light work, and we can see here we've got a much smaller area of bone injury now evident. And at the walk was slowly increased. The dressage work was limited to Grand Prix work only 3 days a week, with the other days walking only. It was maintained on this program into competition. And prior to competition, we can see we've got complete resolution of the middle phalanx bone injury. The horse then competed very successfully at international level at 10 months from the original injury, and at top championship level at 12 months, and was still competing at top level 2 years later. So this horse had a middle phalanx bone injury, did really well, in spite of having other things going on. However, this horse had a different progression. It was a 4-year-old dressage horse with intermittent lameness. For 6 months, which blocked to a Parasagital. We can see we've got dorsodistal middle phalanx bone injury. We can see here, I would always look really carefully at the joint, because we want to see if we've got articular cartilage damage or any subchondral bone damage. And this looked really good when we were looking at it. However, at 6 months, the horse was still lame, unlike our previous horse. And when we look here, we have got pathology here in the articular cartilage and subchondral bone. So it is possible that this happened at the time of the original injury, but is only evident now on our repeat MRI. So now we are now by doing the repeat MRIs, we have an idea of what is going on with this horse and why it might still be lame, or what the prognosis is going to be for the 2 different horses. Just an osteocyst-like lesion, just to show some follow-up on this. This was a 3-year-old dressage horse. This was seen on a pre-purchase examination. The horse had no lameness. It was evident in radiographs from 1.5 years before retrospectively. And we can see we've got this osteocyst-like lesion, which appears to go through the subchondral, or has got a small hole through the subchondral bone plate. That doesn't mean the articular cartilage is not complete over the top, but we do have a small area within the subchondral bone plate. And you can see here the cystic lesion itself has got fluid signal within it, but is not got any in the surrounding bone. So we MRI'd this horse for other reasons 3 years later, and you can see that this osteocyst-like lesion is still there, reasonably similar. The hole through the subchondral bone plate is no different. This horse is still sound in doing small tour work, and was still sound 2 years later from there, working at Grand Prix. So quite useful to know that this hasn't significantly changed and that the horse is able to work. What about articular surface pathology? So articular surface pathology, when we see pathology that is quite significant, like we have here, the articular cartilage and the subchondral bone plate with fluid signal, loss of articular cartilage, then I would be concerned about the prognosis for this. I think the ones that, and you can see here, we've got a clear loss of articular cartilage. I think the ones that are more challenging are the ones which are less advanced. So I just think I thought it was quite interesting to follow this horse, which we MRI'd not particularly for this lesion, but this is when we first saw the horse, and we've got, I would say we've got abnormality here in the articular surface, articular cartilage on the medial aspect of this joint. So this was then, the horse was lame and blocked out to his distal interphalangeal joint. This horse was followed later on, and we continue to have what is a fairly similar findings and here we've got on T1, T2 star, and T2 fast spin echo. We can still see this on all of the different imaging sequences, and we can see this again 4 years later. It's still very similar. This horse was medicated with IRAP on various different occasions, and we can see here, January 2020, we've got, I think, slight irregularity of the subchondral bone here, but the articular cartilage really has not changed that much through this time period, whether that's due to medication or that's because this was never really a big lesion, or whether this is, or it's just been static, I don't know, but I thought it was quite interesting to follow that. Just because I think often I don't get to follow these, particularly in the distal interphalangeal joint. Now, this horse with our articular cartilage injury was MRI'd because he became lame at a subsequent point, and had a deep digital flexor tendon injury. So I thought we might follow that instead. So we've got a deep digital flexor tendon injury here, which is high signal intensity on T2 fast spin echo, involves the dorsal margin, high signal intensity on stir images, and high signal intensity over a larger area on T1 images. And this is also, which you can see on the frontal, but this horse also has increased stir signal intensity in its navicular bone. And I think a lot of horses that have got deep digital flexor tendon injury also have increased signal intensity in their navicular bone, which is probably part of the biomechanics, trauma, inflammation. I think it was, and I think it's quite interesting to follow these, because a lot of times in my experience, we may have a continuing evidence of a deep digital flexor tendon injury, but we get resolution of the navicular bone fluid signal, and often these horses are more comfortable at that stage. So this horse was re-MRI'd 4 months after the initial exam, and we can see after when we look at 4 months, we have resolution of the increased signal intensity on stir images, marked improvement on T2 fast spin echo, but we've still got quite a significant increase in T1 signal intensity, and the navicular bone, now the fluid signal has resolved. So this horse has clinically improved and was now only very mildly lame. But what was useful was to be able to see what was actually happening to the bone and the tendon at this point, because this could be, for me, a horse at 4 months that feels clinically much better, but when we look at the MRI, the horse actually still has a massive lesion in the deep digital flexor tendon. So I think at 4 months, it's really 4 to 6 months, it's really quite useful to rescan these for decision making about what we can do. So we were confident to say, well, I think we'll put this horse back into exercise. So the horse was gradually increasing exercise period at this point. It was sound 2 months later with gradually increasing exercise, and was in full exercise and sound 6 months later, and went back to eventing, still being in work a year later. So whereas I will often see horses that at that stage still have significant deep digital flexor tendon injuries, and I would be much less confident about putting those back into exercise at that point. What about the fetlock? Following fetlocks can be really useful, particularly for bone injury. So this is an endurance horse, and this we're looking at third metacarpal bone injury. So this horse had sudden onset severe lameness after 120k race, 17 days prior to imaging. The horse was now 2 out of 5 lame, consistently negative to a pastern ring block and positive to a low 4-point block. And we can see on these images, the horse has got marked fluid signal particularly in the axial aspect of the third metacarpal bone, but extends across the condyles, which we can see on low signal intensity on T1. We've got fat fluid cancellation artifact on a T2 star, and we've got high signal intensity on stir images. So this horse was in walking exercise at this stage, and at 1 month was re-MRI'd. And what I think is interesting to see at this point is we now have a much more defined lesion in the parasagittal groove area of the metacarpal bone. And I think that that was not evident on our first images, where we had generalized bone injury, and here we've got a much more defined area where we've got bone pathology. So it gives us a little bit more idea of what's going on and what we're following. So the horse stays in walking exercise for 1 month. At 3 months, we re-MRI, and we can see we've got some more defined decreased area of fluid signal, more defined around the parasagittal groove. The horse is in walking exercise still at 5 months. It starts in light training. We've got more resolution of the fluid signal at this point. Again, it's still around that parasagittal groove. So the horse is in light training, and we want to know if the horse is in light training at this point, does the fluid signal increase or decrease? Because if it increases, we're going ahead too quick. If the bone is coping with it, then we can keep the horse going. So at 8 months, the horse was in light training, and then at this point, we can see at that level of training, we've got resolution of the fluid signal, we've got filling in of the area that we were concerned about, and the horse was then put at this stage into full training. So this helped us decision make on our exercise as we went through. This is a different horse, which is an endurance horse, lame for 4 weeks, and we can see we have got a parasagittal groove bone injury here. This horse did not have a re-MRI, and at 4 months was returned to work. And we can see at 6 months it was MRI'd, and we've got a more severe bone injury than we had the first time round. So generally we would have much preferred to have re-MRI'd this horse at 4 months and decision made about whether it was appropriate to put it back into higher intensity training at that point. What about a comparison of CT and MRI? I think CT is really useful for telling us about bone structure. really useful turning is about bone structure, and we can see here an incomplete fracture here in a condyle, evident on CT scan as a cone beam CT. It's got moderate left hind limb lameness. It blocked out in the fetlock and a low 4-point block, almost negative on radiography, but we've definitely got a CT injury. On MRI, we've definitely got fluid signal in this area, which so it supports entirely that we've got a fracture line. In addition, on the MRI, we can see that we've got a split in the suspensory branch as it's coming down close to the insertion. So in addition to the fact that we had active bone injury on MRI, we could also see a soft tissue injury, which we couldn't see very well on this CT. So what happened 3 months later? 3 months later on CT, we now can't see the fracture line. So that's great. But on MR, and these are reversed, just the opposite way round. So it's the same condyle, it's just they are in reverse. We can still see on MRI, we've still got fluid signal. So the MR here, the repeat MR, would give us, I would be much less confident, even though this is filled in, I wouldn't be totally happy with this horse returning to full training at this point based on the MR. I think the other thing that was interesting to follow with this horse with the MRI is the medial branch of the suspensory ligament and the extensor branch. So we can see here, and these are the time scale, so these are the months. So this is the first MRI, month 0, and we can see we've got injury to the suspensory branch and we've got the extensor process. Injury here to the suspensory branch, and we can see this is gradually improving over time and resolving, and at this point it's going back into full training. So following the soft tissue injury is also useful. So I just put this in as for monitoring bone healing again. Here we've got a saucer type fracture on MR, and this is quite a severe injury at the time, and this horse was followed, and this is the final 12-month follow-up where we can see complete healing and filling in, and I think it's just quite nice to be able to see that does happen. For our horses that are doing sports like show jumping and dressage, rather than racing or endurance, we tend to see a lot of sclerosis on the dorsal aspect and injury to the proximal phalanx, much more mid-dorsal to palmar. So we tend to see hyperextension injury related to the sagittal groove, further palmar than we would in a racehorse, where it would often be on the dorsal aspect. And I think the proximal phalanx and the third metacarpal bone are also therefore quite interesting to follow in our jumpers and dressage horses. So this is a show jumper jumping at Grand Prix. It's had an intermittent mild lameness that kept recurring after jumping. It blocked to an abaxial sesamoid block, so it was booked for a foot MRI only. And we MRI'd the foot, which had mild podotracheal apparatus and distal interphalangeal joint osteoarthritis. But for me, this history was a little bit more, I was much more nervous about this being a fetlock or proximal phalanx bone injury. So we also imaged the pastern fetlock, at which point we saw sclerosis of the dorsodistal aspect of the third metacarpal sagittal ridge, which we do see in our show jumpers. But in addition to that, we had got evidence of resorption in the sagittal groove on T2 phosphon echo here. We've got fluid signal in within and surrounding the sagittal groove. We've got prominent vascularity and significant fluid signal, as well as bone resorption. In addition to that, I wasn't totally happy with the oblique sesamoidian ligaments, which were asymmetric with a higher signal intensity in the lateral rather than medial. So this horse was on walking exercise, treated with IRAP. It was re-MRI'd 6 weeks later because they're anxious to take this back into competition. And we can see at this stage, what I think is interesting, we've actually got increased area of resorption than we had on the first set of images. So this horse is rested and we've got more resorption. And we've still got fluid signal, but it is much more isolated and focal around the sagittal groove. And I think these are evident again on our oblique sesamoidean ligaments. So I'm wondering if this is a stage of remodeling. Have we got more resorption at this point, more osteoclastic activity? Is this because we put the horse in walking exercise and we're not working it? But we've certainly got more resorption. So this horse stayed in walking exercise, but we increased the duration of walking exercise. So the horse was walking for quite a lot of period of time. By 14 weeks, the horse was not lame anymore. And when we look on the images, sorry about my computer, we've still got resorption, but it's a little bit less extensive. We can see here. And the stir signal intensity is a smaller area and more isolated. So we felt that we wanted to try and stimulate the bone at this point. So we added small amounts of trotting with significant recovery time during sessions. So trotting was initially only a couple of times a week or 3 times a week. And then the horse gradually increased the amount it was doing. The horse stayed sound and was jumping successfully 4 months later. And the horse was still show jumping 6 months later or a year later, but was having ongoing MRI evaluation just to determine and guide competition and jumping frequency, because this is a likely repetitive overload bone injury. And so giving the bone sufficient recovery time to manage coping with the amount of jumping it's getting, I mean, it could just about keep this horse in competition. I think this is following an endurance horse through a period of training, trying to balance proximal phalanx bone injury and training compared to injury, while this horse is potentially training and coming out of training following what's happening. So I just think it's quite interesting to see, because I don't think we know anything yet, basically, is my bottom line. So we've got a horse here which is intermittent left forelimb lameness that blocks to an intra-articular fetlock block. And you can see we've got evidence of bone injury that's quite extensive in the distal aspect, including the diaphysis and metaphysis of the third metacarpal bone and the proximal phalanx, particularly around the sagittal groove. So this horse was rested and put into walking exercise. So box rested for 2 months and walking exercise for a month. And you can see at this stage, we've got considerable improvement in the third metacarpal bone, considerable resolution of the fluid signal. However, we still have some fluid signal in the proximal sesamoid bone and the third metacarpal bone. The proximal phalanx is better defined. So we're pleased with this progress. It's rechecked again then at 5 months, and we've got further improvement in the distal diaphyseal and the condylar area. So a recheck at 7 months. It's been walking, and at this point our bone looks really pretty good. So we're pretty happy with that. So the horse goes back into work. It's working well without lameness or clinical signs. But if we look on an MRI, we've got masses of fluid signal. We've got masses of vascularity. We've got fluid in the proximal phalanx, fluid in the distal aspect of the third metacarpal bone. So the horse is not lame, but things are going on that are really quite odd. And this is not the only horse that I've seen this in. I've seen this in quite a lot of horses. So I think it's quite interesting that we just don't know what exactly is happening with these. So after the last MRI, the trainer decided to keep the horse training because the horse was clinically well. It was cantering daily and not lame. And you can see at this point, as a recheck of 10 months, that actually it's better. We've got resolution of that fluid signal. So you'd think it was better at this stage than it was. We've still got some odd patterns, but the horse is looking better. At 13 months, it raced, but then was lame after racing, blocked out. And we can see we've got recurrence of this fluid signal, but it's not extensive. We have another recheck. The horse has been resting and we've got resolution of all the fluid signal. Everything looks pretty good again. So it looks like the horse is coping quite well with that. However, it was then put back into work, continued work. It started racing again. And 2 years later, we have sudden onset lameness. And again, we have a severe proximal phalanx bone injury that is more severe than we've had on a previous occasion. So I think, although I think it's really useful to MRI and follow MRI and use that to guide, I still think we don't actually know anything. So, they don't always do what we think. So we need to know an awful lot more about what happens during training. What about the proximal metacarpal region? So the third metacarpal bone and the suspensory ligament are areas that we see a lot of potential injury. Oh, that's interesting. Not quite sure why it did that. Where we see a lot of potential injury in horses that are working, endurance horses, race horses, I see it in show jumpers, dressage horses, anything that may have hyperextension, the fetlock, or repetitive overload bone injury. So pain in the origin, the suspensory ligament on this horse, the medial lobe of the suspensory ligament was enlarged and the horse had lameness. We can see on MRI, we've got marked fluid signal in the proximal palmar aspect of the third metacarpal bone. This is much more commonly on the medial aspect in the forelimb, so palmaro-medial. And you can see here we've got both sclerosis and bone resorption here. We've got disruption of the bone ligament interface and significant fluid signal surrounding it. So this looks like an active on chronic bone injury. So we've got both desmopathy, enthesiopathy, and we've got bone injury. So 2-month follow-up. This horse was treated with laser, shockwave, PRP, hand walking. The horse is now sound, and we can see we've got resolution of the previous previous fluid signal, but we still have some resorption, and we've still got evidence of sclerosis. And the desmopathy is still evident within the ligament. And I think this is a relatively common thing that I see, is that we can get the horse being significantly more sound and happier when we've resolved the bone injury. But the suspensory ligament injury is evident for a much longer time period. So this horse was endurance horse, 12-year-old, 3 out of 5 lame after a ride. We've got marked fluid signal here, again, palmaro-medial. Again, we see the bone injury, and we've got disruption of the bone ligament interface here. But we don't have as obvious change in the ligament. So 4 months. So this was the first one, and then 4 months we've got bone recovery. This actually looks quite nice and smooth. It's still thickened, but it's quite nice and smooth. We've lost the fluid signal. It's sound hand walking, so the horse goes back into training and racing. So this was palmaro-medial. At 12 months, there's new bone pathology, but this time it's on the lateral aspect. So probably we've changed the biomechanics of the horse somewhere or other. We've still got evidence of medial lobe abnormality, but our bone injury is now lateral, which I think is quite interesting. At 18 months, the horse is sound, and we've got resolution of the lateral aspect problem. And at 21 months, we've got complete resolution of the bone, but we've still got abnormality of the suspensory ligament. And here you can see damage within the collagenous tissue of the suspensory ligament here in the classic area that I would see it in the dorsal aspect of the medial lobe. But this horse is sound training, and this was only done as a recheck for the next season. So although we do see, I think, long term we may see changes in a suspensory ligament that may still not necessarily be preventing the horse from being sound and working. So it's a dressage horse. It was 3 out of 5 lame, sudden onset pain, mild swelling, and the horse had a recent foot pain and had its shoeing changed and changed its movement pattern in relation to that, and then had this sudden onset proximal metacarpal injury. And I think it's interesting because this has occurred on the lateral side, which is a much more unusual side for it to occur, and the horse's foot lesion was on a single side, so I think it probably altered its loading while it was still in work. So we can see fluid signal in the bone, including at the interface between the second and the third, the third and fourth metacarpal bones. We can see here we've got damage to the suspensory lobe, medial lobe as well. 6-month follow-up exam, we've got resolution of the bone injury. We can still see enlargement of the medial lobe and some slight changes here in the collagenous tissue, but the horse is sound and walking turnout, and it returned successfully to International Grand Prix dressage within 12 months of the original injury and was still competing with high scores 3 years later as with top placing at championships. So even though we had that suspensory evident there, I think the other type of bone injury sometimes we see is at the articulation between the metacarpal bones. So this is a fracture, incomplete fracture here, extending from the articulation between the second and third metacarpal bones. It was a middle-aged dressage horse at medium level, acute onset, severe right forelimb lameness. It was particularly lame on turns and circles, and it blocked subcarpal, and it improved when it was treated its carpal joints, but lame as soon as it was trotted again. So this was followed 5 months. By 5 months, it was sound and walk and trot in a straight line. We can see we've got improvement, resolution. We've got filling in of the fracture line at this point. 8 months recheck, we can see the fracture line is resolved. We've just got sclerosis in the area, a resolution of the fluid signal. The horse was in increased exercise, and we had a good outcome with this horse. So we judged the progress with this horse each time based on the MRI. What about proximal metatarsal region? This is a 2-week duration marked lameness, blocked subtarsal, and we can see we've got marked fluid signal in this area in the region of origin, the suspensory ligament, marked fluid signal here. A 2 months follow-up, this horse is now mildly lame in a straight line, but still lame on a turn. And we can see there's improvement here. We've got some sclerosis, but improvement by 4 months, we've got significant resolution of the fluid signal. The bone is looking significantly better, and the suspensory ligament is improved. This horse is now trotting a few minutes a day in a straight line. So then there was a question about whether this horse could go on a water treadmill just as part of the rehab. So, and we find the water treadmill is really good for working the hind limbs and getting them stronger, as well as the pole work. So I got tired of MRI images, so I thought I'd just put in some nice little videos at this point, because we'd use this as part of a lot of our rehab. And this was just another similar bone injury that we saw a different horse, which was following surgery and brought into work very early, and just as a bit of a warning to bear that in mind too. So just carpus, just to remember, bone injury in the carpus is quite useful to follow, may be useful in any horse that's doing high intensity training, but this is a 2-year-old thoroughbred. It's got sclerosis of the dorsal aspect of the carpal bones, sound, and in training. However, it's now lame, and at this point we've got evidence of not just sclerosis, but we've actually got a fluid signal here. And so keeping an eye on whether we've got fluid signal and how active this is what gives us an idea of what's happening with bone remodeling and whether that is adaptive. Sclerosis of the tarsal bones can occur in horses with undergoing high intensity exercise and may be a risk factor for fracture. So this is something that can be monitored. If you start seeing fluid signal within this sclerotic region, then I think be careful that we don't end up with a fracture, which we may end up with, as I've experienced. Just to follow here, a sagittal plane talus fracture, which we can see, fairly acutely, and I've seen a few of these. And this was managed conservatively, and at 6 months we've got significant sclerosis and filling in of the fracture line. So the decision could be made at that point to do increased exercise. So what about the value of repeat MRIs? I think they help us improve diagnosis, assessing response to treatment. And as I said at the beginning, I think it helps us monitor healing and the response to exercise. So I think it's really useful in decision making. So there are millions of other cases I could use as examples. I just tried to pick some out. So hopefully some of those were interesting. And if you have any questions, please let me know. I think Lucy's trying to talk, but is still on mute. So, if I,
Hello, sorry about that. Thank you very much, Rachel. Sorry, slight technical hitch there with the unmuting. We have got one question from the floor, and if anyone else has any questions, please do feel free to put those in the chat box. The question that we have is, do you feel that cases like the one, so this is going back to a foot case, do you feel that cases like the one with the subchondral bone injury and articular cartilage damage are predisposed to subluxation of the distal interphalangeal joint?
I think any horse that has got an alteration in congruency of its articular surface is potentially at more risk. So at one stage I thought horses with osteocyst-like lesions might be more at risk of having collateral ligament injury, but I have no proof of that at all. I think that if we've got a horse that is not able to have a joint that fits one part onto the other, then I think it makes logical sense that it's more likely to damage at least a collateral ligament. Whether it's going to completely luxate or subluxate, I don't know.
Yeah, I think it's interesting, and certainly there's been some work, hasn't there, looking at congruency of the joint in a sagittal plane, but I don't know that anyone's looked at it in a frontal plane, which might be quite interesting to maybe have a think about in these cases. Another question is, do we charge less for repeat MRIs or do we charge the same for that?
The same. I think that actually it takes you longer to assess a repeat MRI because you have to compare every single image with the whole previous MRI. So it's not a time-saving thing to do. The only time it might be useful to take less, it might be useful, or you could spend less time doing it, is if you had a very specific couple of sequences that you were assessing a very specific thing. But because with an awful lot of these horses, we're not looking at a single type of injury, we're looking at a bone injury and a soft tissue injury. There are multiple things going on that we're monitoring. And I think that's where MRI has taught me so much about. It's so easy to classify pathology as a single entity, and actually the biomechanics mean that so many things are injured. If you've got one structure that's injured, then a whole lot of other things have also been affected, almost certainly. So if we do follow on a repeat MRI a very limited number of sequences, we still might be missing things. So it's probably better to still do it properly.
Certainly I've had that experience where I've tried to do limited sequences and spotted something in the corner and gone, well, actually now I need to do more. And certainly I think it's very easy to overlook new pathology if we're only doing limited sequences. Following on from that question, when would you recommend a repeat MRI? Do you recommend it in all cases, or is there a certain type of pathology that sort of triggers alarm bells and you think, actually I really need to see this again?
I think that if you've got a severe injury early on, and you're trying to make a decision about, say you're trying to make a decision about whether it might need surgical management at some stage in this recovery, or it might need a very different management program, and that could apply to almost any of the injuries. So bone injury is the easiest one to follow, but that still could be your deep digital flexor tendon injury. What's happening to the navicular bursa adjacent to the deep digital flexor tendon injury that may not have involved the dorsal margin before, but actually it does on later on. So I think generally, if I'm looking at something like a deep digital flexor tendon injury or a soft tissue injury, I'm more likely to image at a longer time period, so maybe a 3 or 4 month time period. Whereas if I'm looking at a bone injury, which might require decision making more quickly and might change much more quickly, then I might look at it. It's more about the time scale, so I might look at it then at a month. So it depends on what the injury is, the specific injury is, and what if it might be a penetrating injury to the foot. We need to know what's happening with that, and because sometimes the clinical picture does not reflect what's actually going on, or the clinical picture is fine, and then after, day 51 it's sound, and then day 52 the leg falls off, which sometimes does happen. And I think that if you had MRI'd it somewhere in that process, you might have known that things were about to break through a structure and you need to do something more drastic.
I think it's always, and so there's another question relating to this. I think we're always spending a lot of time looking at the cost benefit analysis of this. Obviously, MRI is a relatively expensive procedure, and we're often looking at a limited budget or trying to get as much as we can for the money. So the follow-up question is, do you discuss or plan the likelihood of repeat MRIs with the owners from the start? And certainly my suspicion would be a bit easier in a competition horse population than a leisure horse population.
Yes, for the horses, when I first MRI, and I don't know what's wrong with it, I won't necessarily say we need to keep repeat MRIing, but once I've got a diagnosis, if there's something in that diagnosis that makes me think it would be useful to monitor it, I will talk to a client about that at the first MRI. So it will go home with it would be useful to MRI this horse at this stage to decision to make about the next process, or to give you more information about the prognosis. And then it's up to them whether they want to do that, or up to referring vet, or whichever stage whoever is your client in that process. And some people are, whether or not it is a competition horse, some people still want to know that. And even if that means that they are confident about, even if it's about, please can I take my horse off box rest earlier? Is it looking good? If so, please can I start doing more with it? And for some people who are not, it doesn't have to be a competition horse. It's just that for them, that is a really important thing, because it's so hard for them to do it.
Yeah. What would you say your sort of percentage uptake of repeat MRIs is with your clients and in the population?
I don't know the answer to that, really. I would say I think it does depend on the clients. I think for the high level competition horses, it would be very high. For the leisure horse or the much loved horse, still reasonably high. I think it depends. it depends on, I think it just depends on them understanding whether it's going to be a benefit or not. And if they understand it might be a benefit and it will help them with decision making, I think a lot of people will go with that.
Yeah, I agree. I think it's all in how you sort of discuss it, isn't it? And these, you lay out the potential flowchart of what might happen, and people take the path they choose. I think we've just got time for one more question. Looking at the unusual fetlock patterns, I think that you discussed in the endurance horses in response to training. Do you think this is occurring more in a specific discipline, for example, endurance horses, or do you think that these horses are just MRI'd a bit more regularly and you're seeing it more?
I've seen it in horses doing a variety of different sports, and I think the endurance horses, as you say, is probably because we've actually MRI'd them over an awful lot, because they are a population where there is concern about catastrophic injury and concern about severe pathology, and they can afford to do it, so they do follow them very closely. But I've seen it not just in endurance horses.
Okay, it's really interesting. Those were really, really interesting images, especially with the degree of change that you're seeing where the horses sound. Certainly, if you just looked at the images, you'd be like, its leg's about to fall off. Yeah. And then actually, when you get the clinical integration and realize the horses sound and cantering every day, I think I would be panicking slightly that the horse's leg was about to fall off, but maybe less concerning if you've had the progression rather than just doing it at one time point.
Yeah. I think it's fascinating, and I just think we don't know enough yet.
I would agree. I think that's probably about everything question-wise from the floor. So I think all that remains is for me to say thank you very much to Rachel for a very interesting and informative talk with some very beautiful images. And thank you all for attending. The webinar recording will be available to everybody, and a link will be emailed out within the week for you all. So if you've got any specific questions, please do feel free to email us if you think of anything after the event. And thank you all for attending.